So in this second video in the plenary on pandemics, I'm going to go into this next section thinking about past pandemics as a precedent for the current pandemic that we're facing. Now, one of the things that you may have felt if you've been reading the news like I have is this interest in all the stories about comparing past pandemics to the present one, and also how coronavirus is affecting other countries versus here. And there was a really interesting article written by an Italian novelist, um, the Melandri, who's very celebrated in Italy, and she wrote a letter published in the United Kingdom journal The Guardian to the British, and she says, "I'm writing to you from Italy, which means I am writing from your future. We are now where you will be in a few days. The epidemic's charts show us all entwined in a parallel dance. We are but a few steps ahead of you in the path of time, just like Wuhan was a few weeks ahead of us. We watch you as you behave just as we did. You hold the same arguments we did until a short time ago. Between those who still say, it's only a flu, why all the fuss? And those who have already understood. As we watch you from here, from your future, we know that many of you, as you were told to lock yourselves up in your homes, quoted Orwell, some even Hobbes. But soon you'll be too busy for that." And I've included the link to this letter because she goes on to talk about all the things that they're doing in Italy and predicts that these are the things that people will be doing in the United Kingdom. And I would predict that these are things that we'll be doing here in the United States. So there's this analogy being drawn between the pandemic in Italy, which is early, they are in our future. And if you look at what's happening in other places and then see what's happening here, you can see a kind of logic to the pandemic and how it plays out. There's a graph here that shows all the different countries, and there's been this phrase of exponential growth. And the graph shows that the increase in the number of confirmed cases is growing exponentially. And what this means is, depending on the period of growth, countries or regions like Wuhan, the epicenter in China, Italy, Spain, and probably many parts of the United States, especially New York, are going at one rate of rapid exponential growth. And this means that the experience for people in those centers is very similar. You have the same kind of collapse of medical system, rapid amount of people who are getting symptoms. And so this is why this Italian author is able to talk from the future, because there's a similar kind of experience of what exponential growth is. The other chart that I found really interesting to try to make sense of what's happening is a graph that shows the lag time between people getting infected and people getting hospitalized or deaths. And so if you look at this chart, you can see green measures, which are the amounts of people getting infected, and then a lag time of about 2 to 3 weeks. The brown or the orange graphs, which shows the official hospitalizations of people. Now, this idea of a lag time is important because what it means is that what we're seeing now in terms of the actions and in terms of what's happening in terms of infections reflects actions and policies that happened 2 to 3 weeks ago. And this is why this Italian author is saying, I'm in your future, right? Speaking to you now, you're just seeing the beginning of the infections. In a period of days or weeks, you will start to see the same kind of hospital collapse that I see here in Italy, or that we Americans looking over at Europe can imagine what our future will look like. And for me, this chart taught me to be future-minded. As I was looking at this, depending on what people are doing now, you can anticipate what's going to be like in 2 to 3 weeks. This is the kind of thinking I've had for a couple months now. And I was aware of these connections about what was happening in China and what was happening in Spain and Italy because of my personal and professional world involves people in these countries. I was invited to teach a summer course by Auburn University with engineering students in Wuhan. And so as early as January, when it was reported there was an outbreak there, I was very aware that this place that I may be going in the summer is having this substantial epidemic. I lived in South Korea during MERS, which I'll talk about in a second, which is Middle Eastern Respiratory Syndrome. In the outbreak there, I watched as the Korean government struggled with how do you actually do surveillance. My wife has family in Italy and Spain. And so when our family in Italy went on lockdown, over a month ago, we were already thinking about what that would be like for us. And then likewise, when our family in Spain went on lockdown, we were thinking about how it was inevitable it would come to the United States. So if you had been watching these things closely in Asia, Europe, then by February 28th, when there was community spread in Washington state, you would have anticipated where we're going to be, especially given the lack of government response. By March 10th, I knew that we would be in a shelter in place by the end of the month, and that infections and deaths would be rising as they are now. I anticipated that our infection rate and death rate would parallel Italy's, given the slow government reaction. It's very similar to the slow reaction in Italy and Spain. And that's why this author here says that China's lockdown slowed the spread in January and gave the world an extra 3 weeks. And he argues that we wasted it. And he goes on to say that if you are Italy, maybe it's understandable because Italians and Europeans didn't think that what was happening in China would happen in Europe. But if you were Spain or the United Kingdom and then the United States, shame on us. We should have known that it was coming. So anyone paying attention in February could have predicted what was going to happen, and yet we didn't act. Why not? And I think this gets at something really central about disease and pandemics. The thing about infectious diseases is that they reveal the connections between us, even as they are frightening us into ignoring or fleeing from those connections. We think of ways to distance ourselves from the threat. You might think it's a problem in China that doesn't affect me, it's a Chinese disease. It's spreading to Italy, but that's just one unlucky outbreak in Europe. It won't come to my country. It's spreading elsewhere in Europe, and an American might say, we have better measures here, or we have, we can prevent people from coming. And now when it's in the United States, you hear people saying, well, it's in New York City, but that's a big urban cosmopolitan town. It's an urban problem. It won't be a problem in rural communities like mine. So people build up this kind of mental defense or mental distancing to convince themselves that they don't have to worry about the threat until it does touch you in some way. So one of my questions for you is, who is it there? When did this crisis get real for you? Who was affected by it when you were reading about it, or maybe someone that's caused you to actually start to think, what do we do here? Because pandemics show how we're connected. The disease spreads through these connections. It shows our dependencies on each other. Because it makes us vulnerable, we're in need of supply chains. Just as those dependencies are becoming upended, suddenly our supply chains are breaking down. And acknowledging these dependencies is especially challenging for Americans because Americans have a strong tradition of self-sufficiency and individualism. We all create these kinds of defense mechanisms. We want to protect our sense of vulnerability from threats. We want to say it's not me, it's them. And when the disease starts to affect people close to you, it starts to shape that line about who is us and who is them. So when did the crisis get real for you? Who did it affect that caused you to notice and start paying attention? Was it Tom Hanks? Was it the NBA players? For example, my wife and I took some comfort with our newborn baby and thinking, oh, she's fine, it's not affecting infants. And then a couple weeks ago, they announced that a baby dies in Illinois. And suddenly, I imagine parents all across America are getting anxious and worried. What if my baby gets this? What if she dies? So I'm going to offer this as a kind of thesis for this lecture, that pandemics and infectious disease reveal our social connections and dependencies because they travel along those connections and they upend our dependencies, leaving us vulnerable. However, so this is the part where people say the disease doesn't care about who you are, it affects us all, and I think that is true, but there is a kind of paradox. Usually during a crisis, we focus on how we are all affected to build this sense of unity, but afterwards it becomes clear that the risk was different for different people. Pandemics ultimately highlight class disparities, as disease invariably falls more heavily on the poor and most socially vulnerable. The poor are less able to do social distancing because they are workers on the front line. They are the grocers, the truckers, the nurses. The poor have higher levels of pre-existing conditions. They have pre-existing health conditions. They are more vulnerable to what's called comorbidity, right? When people have more than one illness at a time and there are interactions. There are stigmatized classes of people. These are immigrants, the uninsured, who are less likely to receive medical help, often until it is too late. So even though it is true that this disease shows our connections. Those connections will fall more heavily on some than others. Now, as I mentioned, one of the pandemics that has been most commonly mentioned in parallel to what we're experiencing now is the 1918 epidemic. This was a very significant pandemic. Over the course of 263 days, over 33 million people died across the globe. In the United States, it's estimated that 675,000 deaths occurred. This is a lot considering that 1918 population of America was a third of what it is today. Now, I should say, as a point in clarification, it's called the Spanish influenza, but it did not originate in Spain. And this is a good example of the problems with naming a disease after the place that it is associated with. That in fact, during 1918, most of the world was in a world war. This is World War I, at one country that was not with Spain. And so when the outbreak occurred in the spring of 1918, in many different countries, including on the war front, governments involved in the war didn't want to announce it and didn't want to make it obvious that their soldiers were suffering from this. So they said nothing. They tried to cover up reports of this flu. Spain was not in the war, and so it was free to publicize the problem. And so when in the fall the epidemic emerged again in other countries, they were familiar with it because of the news reports out of Spain. And they thus named it Spanish influenza. Today, the World Health Organization discourages people from naming illnesses after the location that is first discovered. It often leads people to falsely think that it has some association with that place, and it can become a kind of barrier to treating it once it has spread elsewhere. So, not the Spanish influenza, but we'll call it that for the time being. The 1918 influenza had a dramatic impact. It was very deadly. Kids reportedly in San Diego would play skip rope singing, "I had a little bird, its name was Enza. I opened the window and influenza." So it had this kind of broad thing that people were grappling with at the time. So today you'll see a lot of people grappling with how do you compare past events with this present moment that we're experiencing? And there are arguments among historians about whether there are precedents for what we are going through. Adam Tooze, historian, wrote an opinion piece in the Washington Post on the stock market crash today, and he says, in trying to gauge the coronavirus crisis, we are all struggling for historical reference points. Which is the historical example to choose? And he says, it's not like World War I or World War II. It's not like the collapse of the Soviet Union in the 1990s. And his conclusion is, this isn't 1914. This isn't 1941. It's not even the 2008 economic crisis. He says it's totally unprecedented. We need to stop trying to compare it to the past. However, other historians have argued, well, actually, we can learn something from the past. John Barry, who's a historian who wrote about the 1918 epidemic, argued that we can learn from the 1918 influenza epidemic that the most important lesson for today is we need clear leadership and public trust. This means having transparency and being open about what you're doing if we're going to win the public health campaigns. A historian of medicine, Michael Brasselier, took a more nuanced approach and argues that there are kind of similarities and differences, and I'll talk about those in a moment. Now, some of the arguments, lessons drawn from 1918, are pretty compelling. One is that this logic of the pandemic and how it grows exponentially means that if you have large public events, these super spreading events, it can create a spike in your local area, which will mean that you'll have more deaths. And the classic example that people draw from 1918 was comparing Philadelphia versus St. Louis. Philadelphia had this huge parade while the pandemic was happening with 200,000 people attending. And sure enough, you can see on the chart, it had a much higher spike and many more people died. St. Louis, by contrast, held to its social distancing and lockdown. It did have a lower thing. It was able to manage a lot of the hospitalizations. It had a slight higher, small bump later on when they loosened up that lockdown. But overall, St. Louis was much less hit than Philadelphia. I don't want to depress those of you who are listening to this, but I am wondering whether we're going to be able to hold football games this fall before there is a vaccine available. If you have 80,000 plus fans in close proximity at the Jordan-Hare Stadium, that might be an incredibly risky event to have. So this is sort of a lesson from the 1918 Philadelphia. Another thing that you can see for the 1918 influenza epidemic is that public health interventions do have an impact on outcomes. On the chart on the lower left, you can see different cities and how quickly they intervened to try to tackle the influenza outbreak. New York City, St. Louis were faster than average, so they had fewer than average deaths, whereas Denver and Pittsburgh were slower to act, and so they had more deaths. And on the upper right, you can see a chart which shows Denver's sort of double peak, and this is going to be the big concern moving forward into June and July. They had measures to slow down the spread with a lockdown and social distancing, and then they eased those up, and so you see a second rise before they implemented again, and then it lowered down. So this indecision, when do we ease up, can have ramifications as well. And we recently had discussions about face masks. I don't know if you've seen the meme of this chart on the upper right circulating where people are showing the exponential curves of different countries. And there are 4 outlying countries, South Korea, Taiwan, and Japan. These are countries that have a tradition of wearing facial masks when people get sick. And some people are speculating that this may explain the lower rate of infections they've had. Now, I have to say this is highly problematic evidence because there are many other variables. I'll return to this at the end of lecture talking about South Korea. But there is a kind of irony about the 1918 flu epidemic for today's epidemic on the question of face masks. So if you look at these pictures on the left, in the United States during the 1918 flu epidemic, got strong public health announcements saying wear face masks. And you can see firemen in Seattle, clerks and street cleaners in New York City out doing their work, and they have these face masks on. Now, in Japan, they looked to the United States, and when the influenza reached Japan, they also emulated or they copied the United States and started wearing face masks. Now, several years later, there was an earthquake in Japan that caused a fire and there was smoke and ash, and because it was still recent, they remembered the influenza epidemic and people pulled out face masks. And then later in the 1930s, there was another flu epidemic in Japan and they pulled out face masks again. And out of this, the Japanese gained a culture of wearing face masks. Their first inspiration was from the United States, but later in the 70s, when pollution started to rise, they found the face mask to be a way of solving urban pollution, wearing the face mask to lower the amount of particulates you took in. Other countries like Taiwan, South Korea, or Hong Kong and Singapore also started wearing face masks because of the Japanese. And so there's an irony that today Americans and Europeans are really hesitant to wear these face masks, and yet it was our wearing these face masks that first inspired East Asians to do this. There is also a kind of lesson to be learned about how much sympathy you have for the people who are suffering most. So with the influenza in 1818, the highest death rates were happening in younger ages, and this made it particularly alarming to people. It was people in their teens and 20s who were dying. Older people in their 60s and 70s seemed to be more immune. Also, New York was very slow to react, in part because the influenza broke out in their poorer neighborhoods. And so people first thought it was a problem of slums. And so before it reached into the upper classes, that slowed down reaction time. However, it was very deadly. In the end, New York did better than other cities in how it responded, although you can see here a kind of peak on this chart on the left that shows how dramatic it was. I think this is a problem today because we think of the coronavirus as a problem for the elderly, for people with pre-existing conditions, and this has slowed down mobilization of trying to get people to react and be careful about it. So there are reasons to compare us with 1918, and there are reasons to think that things will be a little different this time. Similarities. A really key similarity is that this is what we call a virgin soil epidemic. Right? No one's had coronavirus before. In 1918, it's unlikely that anyone had been exposed to that new influenza. And so this is why it can reach through everyone. It can create such a dramatic impact. Similarly, there was large global movement of people in 1918. This made containment impossible. There is large movement of people today, and this has made containment impossible. I think this idea that you can close your borders today is sort of unlikely to solve it because the mobility people is just too high. And you could argue that the political cultural inertia at the beginning of the outbreak, both in 1918 and today, helped it spread in similar ways. But that's where I think the similarities stop, and you have to really focus on some important differences as well. 1918 was a wartime pandemic. There was a world war going on. People were dying and under immense amount of stress and starvation because of this. So it was a much more vulnerable population than you have today. Today, there is much better healthcare and better epidemiological models for how the disease moves. Now, the healthcare thing is going to be interesting to see differences. In Europe, in most of developed countries, they have public health care. This means that they can tackle it as a public health initiative. Many people wonder if it's going to fall more heavily on the United States because we do not have a public health system. Our private health system may end up being slower to react to it in unity. It's less deadly for the young today than it was in 1918, and that in a way is good because it means that the young are potentially less likely to be affected by it. However, we have these silent carriers. The 1918 flu tended to affect you within 1 or 2 days of exposure, and that short time that it sat in you meant that you couldn't expose as many people before you had symptoms. The coronavirus has this silent carrier problem, or the fact that it has later onset, and so it's spread to many people before they're aware. Now, I'm a food studies scholar, and I think a big difference between 1918 and today are our food infrastructures. In the 1918s, people shopped at local markets or local grocers. They wouldn't have had refrigerators. They would have needed to continuously go out to get food. Today, we have these, especially in the United States, this ability to load up our car. We can even order food and have it delivered to us. So that really helps us in terms of social distancing. It's also easier today to shelter in place for these reasons. Refrigeration means we can keep food longer. The consumer packaged goods means that we have longer shelf-stable foods. And we have home entertainment systems, so we're less likely to sort of go crazy and need to go outside than we might have been in 1918. And there is a global response today. There's a global public health and information infrastructures that can get out these messages globally to us that didn't exist in 1918. One of the classic questions I think that people ask when you're in a pandemic or looking at a pandemic historically is, how big was it? What was the biggest? And there's a great link here to a visual online resource that I encourage you to take a look at where it shows different pandemics in history and their relative sizes. Spanish flu, the 1918 flu epidemic, was the third deadliest global pandemic in recent history, so in modern history. The first was Black Death. This is the one that was discussed in the Decameron by Boccaccio. The second most deadly was the smallpox outbreak in 1520, and this one, if you recall from Tech and Civ 1, was due to the Columbian Exchange. So Native Americans didn't have immunity, they were a virgin soil, and when smallpox came over to the New World, it was devastating. And I'll talk about this one in a moment, but the fourth most devastating in terms of deaths was HIV/AIDS, running from the 1980s to present. So if you go, you can take a look at these different pandemics and you can see COVIDs. They are updating these every day compared to the others. Now, another big question for historians in terms of making these parallels with the past is to talk about how should governments react. And so there are a lot of analogies to past crises and talking about what can we learn from these past crises. One of them is this middle article looking at the United Kingdom and its Prime Minister. This is England's Prime Minister Boris Johnson. And it's basically complaining about the widespread use of this war metaphor. And the author argues that the virus isn't like a war. It doesn't choose sides. Notice that the Prime Minister of England gets sick. That's not how it would work in a war. And the article is trying to question this idea of what is meant by this metaphor. And I would say when people talk about this war on the pandemic, what they mean is that the pandemic is very disruptive like a war. There are threats to people's lives. That there is this desire for national unity. That the British want to believe that like World War II, this is a moment where they can unify together as a nation. And there's a hope or an expectation that the government is going to coordinate this public interest, this unity, and also coordinate industry. Other people have looked at this. A business historian, Mark Wilson, wrote an article where he argues, what can we learn from World War II, we Americans? He says, one, the government wants machines like ventilators. It needs to promise to buy them. If the government sets out these big contracts, like it did in World War II, these pool order mechanisms he talks about, it can guarantee that industry will meet them. Production can be scaled up when companies work together. This was true during World War II, that there was intense coordination between companies through the government. The government even built its own factories and then leased those out to companies. And so this government-run, contract-operated plants as a way of speeding up production. One of the concerns, like World War II, that Mark Wilson points out is domestic production versus our dependence on foreign production. This happened in World War II as well with rubber. We had depended on rubber from Indonesia, and then suddenly during World War II that got disrupted, and the United States had to build up its rubber production domestically. And also taxes. He argues that it's incredibly difficult for citizens to carry the cost of all these things, and so governments tend to tax during the wars, and that this, along with fighting corruption and profiteering, is how you can ensure that this crisis is passed. So Mark Wilson's arguing that these are things that happened in World War II which we could do today. But last, you have an article by David Edgerton, historian of technology, where he says the World War II analogy is not helpful. He says, stop using this. He says it's about this fantasy war story, and he describes ways in which World War II actually aggravated social and class disparities. It didn't actually unify people. It tested the myth of self-sufficiency. For example, in Britain, they were an empire. It wasn't that this island was self-sufficient. It was that this island was a global empire, and it was dependent on that to fight the war, and that will be a problem for it today. So here you have historians trying to weigh, how much can we look at these past events to think about solving the present? That said, I do think that one lesson that we can draw from World War II, specifically about medicine, can be seen with the example of penicillin. So penicillin was discovered by a scientist in the 1920s, Alexander Fleming, and not much was done with it for a decade. It wasn't until the wartime when this awareness about penicillin and its ability to be used for certain kinds of infections led governments to intervene and try to accelerate the application of this medical innovation in wartime. So there are a bunch of things the governments did to scale up production for penicillin. First, it suspended patenting. It basically said, all right, you scientists may have discovered this, but for the time being of the war, your patents can't, confer a monopoly, and that would allow different researchers to rapidly innovate and to figure out how to expand the production of it. One problem with penicillin is that when you create the penicillin mold, you have to purify it. And this is called back separation, and this is very difficult. It took a while for them to figure out how to do this. In order to grow the penicillin mold, you needed a medium. The US sort of corn industry developed a byproduct, corn steep liquor, and was able to scale it up under wartime practices really rapidly to provide large quantities of this medium to grow penicillin. And then researchers, because there weren't patents, were able to start looking into creating synthetic versions. In the middle of the war, the first patient was tested in 1942 for staphylococcus infection, and she was cured. And very rapidly over the course of the rest of the war, they scale up production, and Britain and the United States suspended their sort of rules of local production to work internationally to use this new thing during the war front. It's estimated that penicillin saved between 80 million and 200 million lives during World War II. That's 12 to 15% of Allied forces' lives. And it has saved 200 million lives globally since. So this was a very important invention, and it was because of this wartime sense of urgency that they were able to move penicillin from a lab into an application so rapidly. Similarly, after World War II, you start to get the beginning of international coordination in public health, and the sense that we need to scale up public health initiatives to solve global problems. And a good example of this are global eradication campaigns. So if you take something like polio, polio was a very debilitating disease. You can see in the image in the background here what were known as iron lungs. And so people who had got polio, they had lung failure, and that they would have to live in these sort of containers that would sterilize and make it possible for them to breathe. It was a very, very limiting kind of future if you were experiencing polio. It also could cause long-term paralysis. Now, there are some who dispute this, but Franklin Delano Roosevelt, the president during World War II, he was confined to a wheelchair for most of his life. And one explanation of this is that he was exposed to polio and he had infantile paralysis, which is another term for polio. So there was a widespread anxiety about this. As late as the 1950s, polio outbreaks spread huge fear that public pools would be closed, parents would keep their kids at home. It was really scary. It was a kind of fear that people lived on outbreaks that is hard for us, younger than boomers, to imagine growing up with. So that's why when a vaccine became available and was in wide use in the 1950s, many countries really quickly adopted this for mandatory use. By 1960s, a oral vaccine was developed, which was much easier to take. That was very low risk. And so over the next few decades, individual countries, and then starting in the 1980s, global initiatives formed to eradicate polio through the use of these vaccinations. In 1994, the Americas were certified as being polio-free, that there were no countries in North or South America that had it. And in the present day, the number of cases are just in the hundreds. So even though it is not formally eradicated, it is substantially lower. We have only hundreds of cases worldwide. A similar story can be told about smallpox. As I mentioned before, smallpox vaccines were available in the 19th century, and the United States and the British Empire implemented mandatory vaccine programs. Starting in the 1950s, there was a Pan-American Health Organization campaign to end smallpox in the Americas. In 1959, the World Health Organization started an initiative globally. Private organization in the 1960s contributed to this to try to eradicate it. And by 1972, the last outbreak in Europe occurred in Yugoslavia. And then over the next 5 years, people worked to make sure that the vaccine got to all communities where there were cases of smallpox, such that the last natural case of smallpox occurred in Somalia. This virus was effectively wiped out by this campaign, so that now there are some labs that have it for study, but that basically it does not occur naturally. This was a kind of amazing campaign to ensure that this deadly disease would no longer affect people. And sort of as a personal anecdote, one interesting thing about the smallpox vaccine, when you used to get it, it would leave a mark, this scar you can see here. And so if you ask people born before 1972 in America, if they have this, usually they'll show you their arm and you can see that. Anyone born after 1972 in the United States probably wouldn't have this scar on them. And that brings us to kind of where we were at the end of the 1900s and 2000 to this graph I was showing you in the previous video. You can see a dramatic shift in the burden of disease that has happened over the 20th century. Many chronic degenerative diseases rising because of this living longer lives, but a decrease in infectious disease as well. And it's tempting to say that this is because of public health campaigns, but in fact, a lot of the change that you see here has to do with what's called the nutrition transition. And nutrition transition is this idea that in the 19th century and before, people tended to have scarce diets. There was a lot of hunger, but with the growth in production, first in the United States and then in a lot of other countries, you start to have abundance diets. And so you go from diseases of scarcity to diseases of abundance, and that nutrition transition had a lot of impacts on what diseases we experienced. Also, you have the rise of public sanitation. So clean water, toilets, and sewage helped reduce a lot of the rates of infectious disease as well. And these were the main things that caused a reduction in the deaths. And in fact, by the 1970s, many people who were studying public health were making these observations that if you look at the sort of decline in infectious diseases and then the moment where public health interventions were introduced, that the decline happened well before vaccine or well before the public health treatment. antibiotics. So you can see a bunch of charts here where they have this graph and the disease is declining, and then well later there is a vaccine introduced or a medication for it. And this was used by different researchers to argue that all of the idea that public health in medicine is important to reducing disease is actually secondary. It's much more important to focus on broad economics and on public sanitation. And this is what some people called medical nihilism, the idea that in the 1970s there were people saying, well, medicine isn't going to solve the problems. We really need to focus on the economy more broadly. And if you look here, one chart, again, published in the 1970s, was showing 3 lines. The top solid line is the decline in mortality overall. This is again because of this nutrition transition. People are eating better, living healthy, and this lets them live longer lives. The bottom black line is that same decline in mortality, but removing the most deadly infectious diseases. So at the beginning of the 1900s, infectious diseases were a major cause of mortality, but by the 1960s, not so much. The dotted line is why these researchers were so concerned about medical care. That is the rise of the percentage of medical care of gross national product. So you can see skyrocketing healthcare costs for this very diminishing return to help improve people's outcomes in terms of mortality. And basically, this was where people were in the 1970s. There was this idea that there was a victory over infectious disease. There was this concern that we're spending lots of money on health, lots of money on health issues like chronic degenerative diseases, and maybe we need to look for other sorts of solutions rather than medical treatments. And this would be where we were, except for that something happens that makes infectious disease a concern once again. And I will pick this up in the next video. But in the 1980s, suddenly there is this new disease, HIV/AIDS, that challenges this idea that we have somehow conquered infectious disease in modern times.